Welcome to the Bradykinin Beat, a dialogue with global experts about bradykinin-mediated angioedema. My name is Kenny Robinson, and I'm the head of Medical Affairs North America for Pharvaris. Our second episode in this series is called Acquired Angioedema Due to C1 Inhibitor Deficiency, Bridging the Gaps in Clinical Practice. The purpose of our podcast is to examine the similarities and differences between acquired angioedema due to C1 inhibitor deficiency and HAE, address the diagnostic challenges and treatment gaps to help clinicians improve disease recognition, management, and patient care. I now have the distinct honor of introducing our special guest, Dr. Alina Banerjee. Dr. Banerjee, could you introduce yourself to the audience and share a little bit about your medical training and what got you into HAE?
Thanks, Kenny. It's nice to be here today. My name is Dr. Alina Banerjee. I am an allergist and immunologist at Massachusetts General Hospital. I did my fellowship in allergy and immunology at Massachusetts General Hospital and have been there studying allergy and immunology and seeing patients both with hereditary angioedema, acquired C1 inhibitor deficiency, as well as angioedema in general, and so I've gained a lot of clinical experience managing patients with angioedema.
What got you interested in HAE? Do you remember your first patient, may I ask?
Yes. I had a patient with hereditary angioedema when I was a fellow in training. And at the time, we didn't have any treatments for patients with hereditary angioedema in the United States that were approved. And there were some trials starting up. And I really got interested in participating in the trials so that I could give my patient at the time access to a treatment option. And ever since then, more and more patients have come, more and more trials have come along, and my interest has only grown. And I've really seen improvement in care of patients as we've been able to grow FDA-approved treatments for patients with hereditary angioedema.
Thank you. Can you explain to the audience what acquired angioedema to C1 deficiency?
Yeah. So just in terms of terminology, we think about acquired angioedema as a general term that probably includes angioedema for a lot of different reasons. It could be from a medication such as ACE inhibitor angioedema. It could be even a food allergy could be considered acquired angioedema. But for the purposes of our discussion today, you're asking, and we're talking specifically about acquired angioedema due to C1 inhibitor deficiency. So this is actually a condition that's acquired, and individuals present with recurrent episodes of swelling, which is the angioedema term. They don't have symptoms of pruritus. They don't have symptoms of urticaria or hives. So it's not a histaminergic process. It's actually a bradykinin-mediated process, and it's related to a C1 inhibitor deficiency, very similar to patients who have hereditary angioedema with C1 inhibitor deficiency. The difference, and why we call it acquired C1 inhibitor deficiency, is that it's not a genetic disease. Patients are not born with a mutation, but instead, in their 40s, 50s, or 60s, we find that patients have an acquired defect or a low C1 inhibitor function. Oftentimes, it's related to either an autoimmune condition or a lymphoproliferative condition, such as B-cell lymphoma. And those are responsible for the low C1 inhibitor function that we see in these cases.
So can you kind of walk the audience through a little bit about the similarities or the differences between the acquired C1 deficiency and HAE?
Sure. So in terms of similarities, the clinical symptoms between the two are very similar. Patients with both hereditary angioedema and acquired angioedema with C1 inhibitor deficiency present with recurrent episodes of swelling. The swelling can last for 3 to 5 days when it's untreated. And again, the symptoms are bradykinin mediated. We don't believe histamine plays a role. The difference is that it's not a genetic condition with acquired C1 inhibitor deficiency. And instead, we have to think about what is the underlying reason that they acquired this defect. And what we know from the literature and our experience so far is that it's autoimmune conditions such as lupus, or lymphoproliferative conditions or malignancies such as B-cell lymphoma. And so when we see these patients, we think about the age of their presentation. And in hereditary angioedema, it's often young or by the time they're a teenager that we see the symptoms and we diagnose them. With acquired C1 inhibitor deficiency, we wouldn't expect these individuals to present to us at a young age or as a teenager, but instead they've been healthy, they've been doing well, they haven't necessarily had symptoms of recurrent angioedema until their 40s or 50s or 60s. And so we actually have to spend more time in these individuals and the difference in terms of identifying, is there a condition that is leading to this acquired deficiency? And in about 50 to 60%, we will find a condition. But interestingly, there are some cases of acquired C1 inhibitor deficiency where we're not able to identify the cause at the time of the diagnosis of the C1 inhibitor deficiency. But we continue to treat it, continue to manage it, and continue to see if we can identify a lymphoproliferative condition or an autoimmune condition. And I think that's the biggest difference that we see.
In the later decades for that patients with the acquired, is there a difference in terms of male, females, or is it similar in terms of the percentage of them?
Yeah. So with hereditary angioedema with C1 inhibitor deficiency, it is autosomal dominant, and so you would expect that there would be 50-50 in females and males, because autosomal dominant, it's not necessarily preferential for one gender versus another. Certainly there is a role for estrogen and maybe some clinical presentation differences between male and females. With acquired C1 inhibitor deficiency, we certainly know less about it, and it's not necessarily autosomal dominant, so may not present equally in males and females.
So what about the triggers? I know in HAE there's a lot of triggers. Are they similar in terms of the triggers for acquired with C1 deficiency?
In general, 50 to maybe 2/3 of the time, we are able to identify a trigger, whether it's hereditary angioedema or acquired C1 inhibitor deficiency. And the triggers are similar. We certainly know that stress or anxiety, infections, viral infections, estrogen-containing medications like oral contraceptives or hormone replacement therapies can be triggers. Surgical procedures, dental procedures, anything that can cause trauma. So for example, if somebody's biking and they fall off their bike, or they're playing football and they get hit by the ball, or playing soccer and get hit by the ball, or repeated trauma by running, for example, where your foot is hitting the ground multiple times. Those can be triggers. They're not always triggers, but they can be triggers. And so those are the known triggers. But sometimes patients can develop symptoms of swelling where we're not able to identify the cause. And then in rare conditions, sometimes people will say weather changes, certain foods can be triggers. And so we do have to spend time thinking about the history with the individual that's in front of us, trying to identify as many of these triggers as we can. And if we can't identify a trigger, go through the history, what happened in the time leading up to their symptoms. And the triggers will be different. It won't necessarily be the same trigger, but over time, different triggers. And trying to do our best to predict when an attack will occur so that we can help manage their symptoms.
Speaking of the attacks, are there similarities in attack location, or are there differences in terms of location and more severity in certain areas?
Yeah. So broadly, we would think about the categories of attacks as being similar. Patients can have peripheral attacks, which means there is swelling of the hands or the feet. We can have abdominal attacks in both conditions, and abdominal attacks would be abdominal pain, abdominal swelling. We can have airway swelling, so laryngeal swelling, and those can actually be life-threatening, where laryngeal edema can lead to asphyxiation. And then we also think of facial swelling, so eye swelling, lip swelling, tongue swelling. And then rarely we have more recently understood that groin swelling is also a category. But in general, the categories of symptoms of swelling are similar across the conditions. When the attacks occur, they can last for 2 to 5 days if not treated, and so that is similar. We still have a lot more to learn in terms of what is more common, and it's actually very different from individual to individual, and that's what we find more than it is necessarily if it's hereditary angioedema or acquired C1 inhibitor deficiency. And we find that in specific individuals, they tend to have either more abdominal symptoms or more peripheral symptoms. But any individual with C1 inhibitor deficiency can have any of those categories. And what we really have to be aware of and stay on top of is to make sure that if they're having laryngeal symptoms, that we recognize those symptoms immediately. We make sure that they're able to recognize those symptoms, understand what to do when those symptoms happen, because those symptoms and the risk of asphyxiation are real, and we have to make sure that they're able to treat the symptoms so that we can decrease morbidity and mortality from these life-threatening airway symptoms.
Now, how does acquired angioedema due to C1 deficiency develop? The mechanism and the diagnosis. How do y'all go about diagnosing this?
Yeah. So when we think about the pathophysiology, which is the question you're asking, we think about the kallikrein-kininogen pathway. And this is a pathway that is inhibited by the C1 inhibitor protein in all of us healthy. It inhibits the pathway, and so you don't have unregulated production of bradykinin. When you have a deficiency of C1 inhibitor, whether it's a low level of the C1 inhibitor protein or you have a deficiency of the C1 inhibitor protein, the pathway is no longer inhibited and you have unregulated production of bradykinin, and so you have episodic elevated levels of bradykinin. And why is bradykinin important? Bradykinin is then the key mediator of swelling, and bradykinin binds to the B2 receptor on endothelial cells, and that leads to vascular leak from the endothelial cells, leading to increase in vascular leak, peripheral leak of fluid, and that's what's responsible for the symptoms of swelling that we see. And so when you're missing the C1 inhibitor protein or the function of the C1 inhibitor protein, you're essentially not able to inhibit the regulation of bradykinin.
Can you kind of walk us through a little bit about the specialties that treat the disease and that patient journey in the context of how long does it usually take for that diagnosis? Is it very similar to HAE, where before it's like 10 to 15 years before properly diagnosed? And you mentioned earlier, Dr. Banerjee, that it usually comes later when you're up in the 40 years of age. Kind of walk us through that patient journey aspect.
This is a really good question, and I think it's an important one for us to talk about because I think there are a lot of challenges in the patient journey for our patients. First, I think that the condition is underdiagnosed. It's really not recognized, and so it's very difficult for patients to receive the right care because they're not being diagnosed properly. But to think about where the patient journey starts, someone has an episode of swelling. The patient may think they're having an allergic reaction, but in a lot of those cases, they present to an urgent care center or to an emergency department. And so those are the physicians that are seeing them. From there, they may then get referred back to their primary care doctor or their internist. With acquired C1 inhibitor deficiency, because of the age range that we talked about, we're not talking about pediatricians here, but primarily internists, geriatricians, primary care doctors who are either seeing these patients because they had an emergency room visit or because the patient is coming to them saying, I've had several episodes of lip swelling, or my hand has been swollen, what am I allergic to? And from there, it's not often leading to the diagnosis of C1 inhibitor deficiency, but maybe then the patient will get referred to an allergist immunologist, but more because someone is thinking that there's an allergic issue. And then the allergist immunologist is thinking through the differential and maybe thinking about C1 inhibitor deficiency. The other side of this patient journey, though, in this condition is that someone may have an underlying lymphoproliferative condition and they're already seeing their oncologist, or they may have lupus or an underlying autoimmune condition and they're seeing the rheumatologist. And as part of that care, the patient may develop swelling after that diagnosis. And when that swelling occurs, the oncologist or rheumatologist may send the patient to an allergist immunologist saying, swelling happened, is there an allergic issue, rather than thinking about C1 inhibitor deficiency. And so I think there's a lot of learning in all of those areas for those individuals that are having touch points with someone, leading to the acquired C1 inhibitor deficiency diagnosis that could be made by the allergist and immunologist.
What are the challenges of those physicians in terms of those oncologists or the internists in diagnosing that? Especially with the oncologist from the standpoint with the lymphomas, when is it that you all get called in? When the angioedema begins, or I'm just kind of help the audience understand that aspect.
So I think when the angioedema occurs, it's often thought about, oh, somebody's having an allergic reaction, let's call the allergist. And that's great, because then the allergist can think more readily about something that's causing it, and an allergist or immunologist probably has more experience thinking about C1 inhibitor deficiency. But it still requires the oncologist or rheumatologist to be thinking about that. But oftentimes in a patient journey, when someone has swelling, it is thought about as an allergic issue. So the rheumatologist or oncologist may not know how to evaluate it, but they will often loop in an allergist or immunologist at that point, thinking that an allergic reaction happened. Let's get the allergist on board. And then when an allergist or immunologist or a physician is able to make the diagnosis, then there's some teamwork with either the oncologist or the rheumatologist in terms of thinking about how to manage that individual and treating that underlying condition that's contributing to the C1 inhibitor deficiency. And so that's probably later in the patient journey once the diagnosis has been made, but then some teamwork there.
So in that maintenance of care for that patient, once it's been diagnosed, do they stay with allergist immunologists, especially if it's on the lymphoma side, or does it go back to the oncologist on managing just the angioedema side of the equation?
I think it's actually both.
Okay.
So if it's a lymphoproliferative condition, you would want the oncologist to think about treating the lymphoproliferative condition, and the allergist immunologist thinking about how can I manage the bradykinin-mediated angio symptoms while we're thinking about the underlying lymphoproliferative condition. And they both need to go hand in hand, because even if you manage the underlying condition, you can still continue to have swelling. And so they both go hand in hand, and that's exactly the same if it's an autoimmune condition, where the rheumatologist will be thinking a lot about the autoimmune condition, and the allergist immunologist will be thinking about the recurrent symptoms of angioedema. And then certainly there are cases of acquired C1 inhibitor deficiency where we don't know that there's an underlying condition, or we haven't been able to identify where the acquired C1 inhibitor deficiency or the symptoms of swelling have happened first. And so you still need someone to really think about how do you manage bradykinin-mediated angioedema, because that's really what the patient is facing, and thinking about how to treat those symptoms, prevent those symptoms, treat them when they start, and really make sure that when it's life-threatening, as we talked about before, to make sure that there are tools in the toolbox for that individual to be able to manage those symptoms immediately.
What about, just share with the audience any example of any case studies and cases that you've come across as you were talking to your fellows or your residents about this side of the equation of the acquired angioedema due to C1 deficiency?
So I've certainly followed a handful of cases of individuals with acquired C1 inhibitor deficiency, and they have come to me from a variety of places. I've certainly had individuals with lymphoma who have developed swelling along the way and have been referred to us, but more because somebody thought they were having an allergic reaction. But we were able to identify that it was a C1 inhibitor deficiency that was causing the angioedema. Similarly, we've had rheumatology colleagues that are following individuals with lupus or other autoimmune conditions refer in the midst of someone developing swelling while they were managing their condition. But we've also had referrals for individuals that suddenly had tongue swelling and were in the emergency department and weren't on an ACE inhibitor. And we spend a lot of time thinking broadly about the differential diagnosis. And what is really important for the audience to understand is the diagnosis is very straightforward. If you think about the condition, think about labs. It's a C4 level, C1 inhibitor function, and a C1Q. The C1Q is often low. That differentiates it from hereditary angioedema in addition to the age presentation. And then the C1 inhibitor function is low. And those lab tests are very black and white. If you're thinking about the condition, check the labs. You can easily make the diagnosis or reassure us that this is not the diagnosis. And so in our cases, a lot of times we make the diagnosis, And then we either work with the rheumatologist or the oncologist to manage the underlying condition. But it's also important to think about the treatment options for the bradykinin-mediated angioedema in addition to the underlying condition. And if there's no underlying condition that's been identified, to make sure that we follow that patient. But really, our focus as the allergist immunologist is to really be thinking about the bradykinin-mediated angioedema symptoms, making sure that somebody's not going to give them epinephrine or steroids or antihistamines for those symptoms.
Another question on that same line in terms of what should the healthcare provider focus on to enhance the patient's outcome with this condition?
I think it's really about the diagnosis, right? If you can't make the diagnosis or you're not making the diagnosis, then you can't start anything. And so really thinking about educating colleagues that might be seeing these individuals at different places in the patient journey. Once you make the diagnosis, then we're at kind of a different place. And it's really thinking about how to give them the tools to prevent symptoms, manage the symptoms, think about what is contributing to the C1 inhibitor deficiency, and really just managing it in all of those aspects.
In terms of that referral coming to an academic center like yourself, do you see these patients coming more toward an academic center or being treated in the rural community and the challenges there?
So I'm obviously a little biased at being at an academic center, but I think because it's so rare and a lot of non-academic physicians may not have as much knowledge or comfort with the condition because they may not have seen one in their career, we're finding that they're getting referred to the academic centers where either for a referral to make the diagnosis and think about how to manage them, and they may then go back to their local physician for local care with a touch point maybe annually to kind of check in to see how things are going. Is there anything new to think about? Is the treatment plan in agreement with what the physician that has a lot more experience would continue to do? So I've seen both where they could be referred and we kind of own the care versus we're kind of a touch point as the expert and kind of provide insight and guidance on an annual basis back to the physician that's local, so that the patient doesn't necessarily have to travel a lot every single time something changes.
From a medical education standpoint, in terms of education to the healthcare providers, what would you suggest in terms of different types of tools, different type of programs to attend, just to get a better understanding of this rare condition?
It's a really good question. Podcasts like this are great. You can listen to them when you're driving in the car, sitting in traffic. But I think part of the challenge is you don't even know what you don't know. Mm-hmm. And so I think just generally, if you have someone that comes to your office with swelling, really think broadly about the differential diagnosis. You can look up different resources online. There's some really good online places to look. There are allergy and immunology articles, PDFs, meetings. Think about the treatments that are out there and the resources around those treatments to really understand what the options are for patients. But really just knowledge at the end of the day is going to be the most important.
What's your final advice for those providers out there that see these patients, but also those who don't? I know that you share in terms of listening to a podcast like this, but any final advice in terms of some key takeaways?
3 takeaways, yeah. There's probably a lot of takeaways, but if I had to think about 3, I would say that if you have someone that is presenting to your office with recurrent episodes of swelling, one of the first things to understand is it bradykinin versus histamine mediated? And the way to think about that is there urticaria? Are there hives? Is there itching? If there's not, and you really do have someone with recurrent episodes of swelling, get a C4 level, C1 inhibitor level, C1 inhibitor function. So recognize the symptoms as the first step. Think about bradykinin mediated versus histamine. Second, get lab tests if that's where you are. Think about C4 level, C1 inhibitor level, C1 inhibitor function. And third is to understand that there are treatments out there. Go out there, learn about it, figure out if there's a specialist near you who has a lot of knowledge, and work with them to make sure that that patient has the best care. So those would be the 3 big takeaways.
Thank you very much for spending time with us and sharing your knowledge with the podcast audience.
Thank you, Kenny, for having me today.